Okay, good morning, everyone. Sorry for that uh weird startup where it looks like Zoom updated and we were trying to figure out how the chat function worked. And then I was also trying to locate what I was looking for, which is a bio for Dr. Daniel Ho, who is going to be presenting, I think, his first high rounds. Daniel is a second year fellow, but has, oh, Daniel, how many? 2 days, 3 days, 4 days left. And then he becomes a full-fledged attending. But he's from Westminster, California, graduated from UCLA, and completed his residency at UC Davis. Um, his interests include travel ID, global health, and infections and immunocompromised hosts. Got some hobbies. He loves traveling, eating different cuisines, playing video games, hiking, and walking his really adorable dog. And next year he will be going to UCLA to be basically 100% clinical there. And maybe he'll talk about what his job is going to look like. But I'm going to turn it over to him, and hopefully we're not having too much trouble with this chat box. But Daniel, please go ahead.
Good morning, everybody. Thank you, Dr. Blumenthal, for the introduction. Today, my talk is going to be about gonorrhea. Do we need a second look? In other words, oropharyngeal gonorrhea and test of cure. And so for the outline for my talk today, I'm going to be talking about the background of the epidemiology of gonorrhea, as well as increasing antimicrobial resistance, some prevention strategies, including doxypep and the MenB vaccine, new therapeutics in the pipeline, test of cure, why it's important, why it's needed, the pros and the cons of the test of cure. And then I'm going to be talking about the project that I've been working on with Dr. Blumenthal. This project has been adapted from Darcy Wooten, as well as Eddie Hill, another ID fellow. And essentially, we're looking to see and evaluate the completion rates of test or cure at the Owen Clinic and see how, if providers are doing it, if patients are completing it, what are the rates look like? Are there any complications or negative outcomes and things like that? So I want to talk about the project that we've been working on. I also wanted to compare our data at the Owen Clinic to other centers across the US. And then finally, the conclusion. And so for the background, in terms of epidemiology, gonorrhea remains a huge public health concern both in the United States and globally as well. The CDC estimates that in the US, about 1.5 million new cases of gonorrhea occur every year. The chart on the bottom shows data from 2018 for both men and women, and it estimates about 1.5 million incident new cases of gonorrhea in that year. So still quite a significant burden. The WHO in 2020 estimated about an 82.4 million cases of gonorrhea globally, all across the world, with hotspots notably in Africa and Southeast Asia as well. And I just wanted to reveal quickly the most up-to-date STD guidelines published by the CDC in 2021. And so for uncomplicated gonococcal infection involving the cervix, the urethra, the rectum, or the pharynx, the CDC recommends a higher dose of ceftriaxone at 500 milligrams intramuscularly times 1. And if the patient is over 150 kilograms, then 1 gram of ceftriaxone times 1. And if chlamydia has not been ruled out, they recommend doxycycline for a course for 7 days. And then particularly, specifically for pharyngeal gonorrhea, if the patient has been diagnosed with oropharyngeal gonorrhea, then they recommend a test to cure within 7 to 14 days, either with a gonococcal culture or repeat PCR NAT testing to ensure eradication and clearance. And then routine screening for all patients for 3 months due to risk for reinfection, abstaining from sex for 7 days, and then treating sexual partners. They also recommend alternative regimens if ceftriaxone cannot be used. For example, if the patient has a ceftriaxone allergy, then alternative regimen could be with gentamicin, 240 milligrams intramuscular times 1 with a dose of azithromycin, 2 grams. Although the data for gentamicin and azithromycin used for pharyngeal gonorrhea is mixed in terms of eradication for pharyngeal gonorrhea. Similarly, with cefixime, 800 milligrams PO times 1. This is also another alternative regimen. The data for cefixime in eradication for pharyngeal gonorrhea is also limited as well in terms of its efficacy. I just also wanted to go over the history of antimicrobial resistance as it pertains to gonorrhea. So early on, gonorrhea back then already developed a high level of resistance to penicillin as well as tetracyclines. And so fluoroquinolones were used and recommended to treat it around the mid 1980s. Unfortunately, there was growing resistance to fluoroquinolones. And so in 2007, the CDC removed fluoroquinolones from their guidelines. And then in 2010, the CDC had recommended dual therapy with both ceftriaxone and azithromycin to treat specifically gonorrhea, even if the NAT testing for chlamydia was negative. And then there was, of course, increased resistance to azithromycin. So in 2021, they removed azithromycin from their guidelines because of not only resistance, but also other things like it negatively affecting the GI flora. And so now with the most current 2021 guidelines, they only recommend ceftriaxone at 500 milligrams. And in this current era, there are globally reports of ceftriaxone-resistant gonorrhea worldwide, notably in Southeast Asia, for example. In the US, however, from what I have read in the literature, there doesn't seem to be any reports of any ceftriaxone-resistant gonorrhea isolates in the US yet, but there are cases of gonorrhea isolates in the US that have decreased susceptibility to ceftriaxone. And so I wanted to talk about one of these papers. This paper was published in 2024. It mentioned that the first case of an isolate that was decreased susceptible to ceftriaxone was back in 2019, actually, in Nevada. And in this paper, they highlighted two more cases, both in Massachusetts, where they found patients who had a urogenital gonococcal infection. They found the MICs to the isolate was 1 to ceftriaxone, so definitely not susceptible. And they did genotyping and found that they had this allele, this PEN-A60 allele, that conferred a decreased susceptibility to ceftriaxone. In vitro, the testing for this isolate was non-susceptible to ceftriaxone. However, clinically, both of these cases, the patients did well with ceftriaxone, and there was test to cure obtained, and there was eradication as well. And so, with the concern for the increasing gonorrhea resistance, the CDC back in 1986, they established this GISP program or this GIS program, the Gonococcal Isolate Surveillance Project, and essentially just to monitor for antimicrobial resistance for gonorrhea. In 2017, they kind of expanded it a bit to the eGIS program to try to understand if the pharynx or the rectum may be anatomic sites that might harbor more resistances. And this program is really important because findings from this program have directly contributed to the CDC's STD treatment guidelines. And so how this program works is for participating STI clinics all throughout the US, they would send their isolate, the gonorrhea isolate, to the GIS program, and they was tested for antimicrobial susceptibility to see if there's any resistances that they notice with increasing MICs to antibiotics. And so the WHO, they have their own kind of GIST version or the GASP. I believe it stands for the Global Antimicrobial Stewardship Program. And for this paper, they collected gonorrhea isolates from over 73 different countries across the globe, and to see the susceptibility to ceftriaxone for the gonorrhea isolate. So this is data from 2017 to 2018. And so this is a relatively old data. We can see in the US, the rates of decreased susceptibility to ceftriaxone gonorrhea isolates is about 0.1 to 4.9%. Notable hotspots include the salmon-colored, which it represents 5 to 29.9% of isolates that have decreased susceptibility to ceftriaxone. And these are areas in Asia, East Asia, and Southeast Asia. Out of the 73 countries that reported their gonorrhea isolates, about a third of them had gonorrhea isolates that showed somewhat of a resistance to ceftriaxone. And then I also wanted to kind of review the GISP's data both nationally and locally. So this is data nationally from the US from 2018 to 2022. And as you can see here on the top right of the screen, a majority of the isolates in the US are susceptible to ceftriaxone. The blue dotted line here represents an MIC of 0.125 to ceftriaxone, which the GIST program gets alerted when the MIC is over that. And over zero point 0.5 MSC in the red dotted line is considered non-susceptible to ceftriaxone. And then for specific numbers on the chart on the bottom, we can see here that there are some cases of isolates that have an MIC of 0.125. So for example, 8 isolates in 2018, 7 isolates in 2019, 3 in 2020, 3 in 2021, and 0 in 2022. And then even fewer cases of isolates with an MIC of 0.25, about one maybe in every year. And then beyond that, MICs from zero point 0.5 and beyond, which is considered non-susceptible, there has been only one case, and that was documented in 2019. And I think that might be that one case in Nevada. But so far, very, very minimal cases of decreased susceptibility in the US. And then, so this is national data. Um, the next slide is data for Los Angeles. So very similarly as well, most isolates, majority of isolates are susceptible to ceftriaxone. There's only a few cases, 3 cases in 2018 that had increased MIC to ceftriaxone, 1 case in 2019. And then this is local data in San Diego. Also very similar, very sporadic cases. On the chart on the bottom, you can see in 2009, there were 3 cases of increased MICs to ceftriaxone, one in 2010, one in 2011, and then one in 2016. And then beyond that, there hasn't been any so far documented cases of um, decreased stability of ceftriaxone in San Diego. This is a chart that I thought was cool to highlight, just showing the increased antimicrobial resistance to different antibiotics with gonorrhea. We can see here that ceftriaxone is still relatively flat in terms of susceptibility, and then azithromycin is slowly creeping up, and penicillin, tetracyclines, ciprofloxacins have definitely been creeping up over the past decades or so. And I also wanted to highlight, as we all are well aware, unfortunately, with the current political administration and their budget cuts and mass layoffs of public health agencies like the CDC, more recently in April of this year, this article was published in April 2025. The Doge Committee laid off about 30 to 40 workers or employees in the STD branch of the CDC, which is vital for the GIST program. And so the I think the future of the GIST program is going to be very uncertain if not effectively closed because of this layoff. And so from this article, I quoted from one of the prior workers. They said, however, with the lab's entire staff laid off, the GISP and other surveillance programs face an uncertain future. The data will not be there this year, and that makes me sick to my stomach, a former employee stated. Um, the 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 SCD branch for the CDC is also an important lab for the WHO as well to monitor for global gonorrhea resistances as well. And as we are also well aware, the US has also been withdrawing from the WHO as well. So there's going to be a lot of changes in the future, particularly in when as gonorrhea becomes more and more resistant and more widespread, we're not going to have a way to monitor this with the GISP funding cuts. Okay. I'm gonna switch gears and talk about prevention, particularly with the doxypep and the MenB vaccine. Um, th- this trial really, to me, really highlighted the effectiveness of doxypep for prevention of gonorrhea, chlamydia, and syphilis. This was a paper published in 2023. It was done in San Francisco and Seattle, and they included men who had sex with men, transgender women, patients living with HIV, patients on PrEP to prevent HIV, patients who were at increased risk for developing STI infections because of an STI diagnosed in the past year. And so they were randomized to undergo doxypep after condomless sexual activity versus standard of care or no doxypep. And they found that there was 70 to 80% reduction in chlamydia and syphilis and about 55% reduction in gonorrhea. So very significant reduction in bacterial STI incidences. But then I also wanted to highlight some other newer doxypep articles that had lower rates of incident reductions. And so this paper, this was published very recently in this year in 2025. This was a paper that was done in Kaiser NorCal. And in this paper, they checked the electronic medical record for patients who were taking PrEP to prevent HIV. And then in that cohort, they looked to see who were prescribed doxypep, who were not prescribed doxypep, and then they compared the rates of STI incidences before and after doxypep was implemented. And so for this paper, they found that very similarly, there was about 70 to 80% reduction of chlamydia and syphilis with doxypep usage, but the reduction of gonorrhea was significantly lower than the other paper for about 12%. And so for them, they hypothesized that the reason why gonorrhea could be reduced as compared to others STIs like chlamydia and syphilis because of increased tetracycline resistance to the gonorrhea, potentially doxypep or doxycycline not getting adequate levels in the oral pharynx. Um, and so those are some of the reasons that they thought might have been the reason why the gonorrhea reduction was lower. There was also another recent article published as well, also this year in 2025. This was a population-based study that was done in San Francisco. And so they wanted to see the effects of doxypep on STI incidences on a population level when it was implemented in 2022. And so they looked at data before 2022 when doxypep was implemented and then data after 2022. And what they found was chlamydia and syphilis cases decreased as expected. Chlamydia decreased about 49% and syphilis decreased about 51%. But actually, gonorrhea cases increased around this time. And so they had some hypotheses about this. They hypothesized that the randomized clinical trials that used doxypep, maybe those trials were such very well-controlled trials, and the actual community use of doxypep might not reflect that, particularly in the more high-risk populations. They also hypothesize, again, similarly, maybe doxycycline doesn't get adequate levels above the MSE in the pharynx as compared to chlamydia or syphilis. And so maybe doxycycline should be taken within 24 hours of condolenized sex. Maybe that aspect is more important than over chlamydia or syphilis. And again, they also mentioned the concerns for increasing tetracycline resistance with gonorrhea as well as other reasons why gonorrhea cases might have increased despite the implementation of doxypep. And then I wanted to talk about the MenB vaccine as well, which is approved to prevent infections for invasive meningococcal disease. This is a current study that's been sponsored by the NIAID. And so it's a randomized, placebo-controlled, multi-centered trial, which is ongoing right now. And they are randomizing high-risk patients, both men and women, to receive the Bexsero or the MenB vaccine as compared to placebo. So it's an ongoing trial right now to see if there is some effectiveness for MenB vaccine with its cross-reactivity to protect against gonorrhea. Prior to this current clinical trial, there were prior studies suggesting that the efficacy of the MenB vaccine to prevent gonorrhea infections is about 30 to 40%. And because of those trials, more recently, the UK, this is also this year as well, this article in 2025, they're beginning to implement the MenB vaccine to prevent gonorrhea infections in high-risk populations, for example, in men who have sex with men. And from what I'm reading, I believe they're about to implement this protocol in August of this year. And so I wanted to see where that number came from. Where did this 30 to 40% effectiveness in the MenB vaccine to prevent gonorrhea infections came from? And so I found this one article. This was a paper published in 2022. And in this paper, they looked at patients from 2016 to 2018 who were diagnosed with gonorrhea in the East Coast in Philadelphia, New York City. And that was a ton of patients. That was about 167,000 patients. And then from that cohort, they went to see their immunization records. When did they get the MenB vaccine? If they got one dose, which is partial vaccination, did they get two doses or complete vaccination? And then they compared the rates of gonorrhea with patients who are partially vaccinated, completely vaccinated. And so what they found from this paper was that complete MenB vaccination with two doses conferred about a 40% effectiveness and protection against gonorrhea. And then the partial MenB vaccination, which is one dose, conferred about a 26% effectiveness in preventing gonorrhea. I'm going to switch gears now to talk about some of the new therapeutics in the pipeline to treat gonorrhea. There's two of them, so from what I've seen. The first one is olefluoticin. This is a novel antibiotic. It inhibits bacterial DNA synthesis, and it was specifically designed to treat gonorrhea in the setting of resistant gonorrhea, with only ceftriaxone being the available choice so far. Zoliflodacin, this is a powdered medication. You mix it in an oral suspension. And so from this study, it comes in two doses, 2 grams, and then 3 grams as a single dose. This study, most of the participants had urogenital gonococcal infections, and a few of them had rectal, and a few of them had oropharyngeal infections. And so in this study, they randomize patients to receive zoliflodacin at 2 grams versus 3 grams versus standard of care ceftriaxone, 500 milligrams intramuscularly, and they found that there was a 96% cure for urogenital infections with both the 2 grams and the 3 gram dose, and they found that it was a 100% cure for rectal, although the sample size for the rectal gonococcal infections was relatively low, about a dozen or so. Very notably, there was a 50% cure for pharyngeal gonorrhea infections at the 2 gram dose and 82% cure at the 3 gram dose with zoliflodacin. And for the isolates or the patients who had treatment failure, they tested the isolate for zoliflodacin resistance and they didn't find any. So again, they also hypothesized that potentially zoliflodacin may not get good penetration into the pharynx. Most of the patients who were prescribed zoliflodacin tolerated really well. There was just some side effects of GI adverse events. And so this is a phase 2 clinical trial that was published in 2018. The phase 3 clinical trials, from what I understand, is still ongoing and pending. And then this new, also novel antibiotic, gibotidacin, also inhibits bacteria DNA synthesis and replication. This is an antibiotic that was already FDA approved to treat uncomplicated urinary tract infections, but they found that it was potentially effective for gonorrhea as well. And so in this study, this was recently published in May of this year. This is a non-inferiority study. They compared gibotidacin to standard of care ceftriaxone with azithromycin, and this one was only in uncomplicated urogenital gonococcal infections, and they found that gepotidacin was non-inferior to standard of care. Okay, I'm going to be talking about the test of cure now. So the test of cure, why is it recommended by the CDC? There are some thoughts to why the CDC recommends a test of cure. As I mentioned and alluded to already, because of the increasing global emergence of antimicrobial resistance, with more isolates becoming more resistant to ceftriaxone, that is a huge concern. And on top of that, there's concerns about antibiotic penetration into the oropharynx, particularly decreased ceftriaxone levels in the oropharynx as compared to urogenital and or anorectal areas. For example, some studies suggest that ceftriaxone levels in the saliva or the tonsils may not accurately reflect serum levels. So those two are the main things. And most of the cases of oropharyngeal gonococcal infections that have treatment failure are related, or excuse me, most cases of gonococcal infections are related to oropharyngeal infections. And so that's why that's a concern specifically for that specific anatomic infection. There are also other hypotheses as well, because the oropharynx patients who have infection there typically don't have any symptoms. They could have ongoing asymptomatic pathogen transmission. And when Neisseria gonorrhea is sitting in the throat, that can lead to and harbor more resistances, particularly from horizontal gene transfer, where there are already Neisseria commensal organisms in the oral flora. Potentially, the Neisseria gonorrhea sitting in the throat may accumulate resistances from these commensal organisms as well. And so I wanted to list some of the pros and cons for a testa cure. So pros of a testa cure, if you get it, it ensures, and it's negative, it ensures that you got rid of the infection, it eradicate the infection. It also assesses if you had potential treatment failure. And if there was treatment failure, you can retreat the patient again. If the patient did not abstain from sex within 7 days, they may have picked up a reinfection that you might have been able to pick up early. It also is helpful in detecting antimicrobial resistance in cases of treatment failure. And because of reducing treatment failure and because of reducing reinfections, that might reduce transmission as well, particularly because the infections are typically asymptomatic. The cons of a test cure is that it utilizes potentially a lot of clinic resources. There could be a clinic burden for patients to get retested, to get follow-up. Um, on top of that, most patients get retested anyways. So if we're going to test them maybe in 3 months or 2 months or so, do we really need to check another test of cure in 3 weeks? There are relatively low return rates for patients coming in to get a test of cure, and this is likely related to patients with barriers or difficulty accessing care. On top of that, if the PCR or the NAT test is too early, that might detect false positives or picking up dead organism. And if a PCR is obtained rather than a culture, then we can't obtain susceptibility testing. And so, diving into the project that I've been working on with Dr. Blumenthal, these are some of the reasons why we wanted to do the project. So first, we wanted to evaluate the test of cure completion rate at the Owen Clinic. What are the rates like? How does it compare to other centers? Are we doing okay? Are we not doing okay? Are people actually even doing it? Are patients completing it? Do we even need to do it? Are there any rates of antimicrobial resistance? Are there any complications? Do we have patients who have disseminated gonococcal infections that we're worried about? etc. And so we wanted to see in patients that are positive test of cure, what are their outcomes like? Do they have any treatment failure, antimicrobial resistance? And we also wanted to see if there were any provider biases or patient factors that may influence if the test is ordered or not, or if the patient completes the test or not as well. And these are some of our aims. And so for our main and our primary aim, we wanted to determine the proportion of patients living with or at risk for HIV at the Owen Clinic who were diagnosed with pharyngeal gonorrhea infection and who were treated, and then who were then ordered and completed a test of cure. And for our time, we did from 7 days to 21 days. So we expanded it a little bit for more leeway. And we looked at patients between 2020 to 2023. We also wanted to assess the socio-demographic factors associated with patients completing a test of cure for things such as age, race, ethnicity, gender identity, HIV, serostatus, housing, and insurance providers. We hypothesize that patients who have a lot of barriers as it relates to these factors may have more issues with completing a test of cure. For example, patients living with HIV may have more barriers and would have a lower test of cure completion rate as compared to patients who are using HIV PrEP to prevent HIV. These are some of our secondary aims. We wanted to look at the patients who had a persistent positive test of cure result, and see if there is any outcomes associated with that. And our hypothesis here is that the persistent positive test of cure result would be relatively low because ceftriaxone, as the data shows, should be sufficient enough to treat the gonorrhea. This is just a description of our statistics and analysis. Most of the statistics were descriptive statistics. We did some T continuous variables and chi-square testing for the demographics aspect of the project. And so looking at the demographics, I won't go into this in too much detail, but just highlighting some things. For example, median age of 39, for race, 47% white, 34% other, 7% Black or African American, 5% Asian, ethnicity, 51% not Hispanic, 45% Hispanic, gender identity, most identified as male, 74%, unanswered or unknown 18%, and then transgender 5%, with female being 1%, and then a majority using Medi-Cal insurance at 39%. These were the antibiotic regimens in the cohort. 78% of patients received ceftriaxone at 500 milligrams, as the CDC recommends. The 17% of patients who received ceftriaxone at 250 milligrams was likely before the recommendation was changed. And then the 1 gram dose of ceftriaxone, this is typically in patients who went to the ED for another reason and got the higher dose IV. There was one patient in this cohort who received the higher dose of ceftriaxone with concern for persistent positive test of cure result. The 6 patients, or 1.5%, who received gentamicin and azithromycin, these are all from allergies, as from like penicillin or cephalosporin allergies. And there was one patient who only received solo therapy with azithromycin because they did not like the adverse events from the other antibiotics, and this patient also did fine as well. And so for the results of the test to cure, out of the sample size of about 427 patients in our cohort, 82% of patients, regardless of when the testing was done, as long as they had some sort of testing done at their own clinic, they had repeat testing done. Whether or not it was within the test to cure window or not, 82% of patients had repeat testing done. Patients who had a test to cure that was ordered and completed within a time window of 3 weeks was about 21.8%. Patients who had a test cure ordered and not completed. So the provider ordered it, but the patient didn't come in and complete it. So maybe the test fell out or got canceled or things like that was at a 1.4% rate. And we hypothesized that this number might not be the most accurate number. The reason why we did this in the first place was to see if there were any patient factors that might be at play, and in which case the reason why they might not have completed their test of cure. But I think the reason why this number is so low and might not accurately reflect the data is because there are people getting retested anyways. And then the persistent positive test cure rate was about 11.8%. So out of the 93 patients who had a test cure completed within a 3 week window, 11 of those patients had persistent positive test cures. The median time between initial treatment and testing was 67 days, with an interquartile range of about 19 to 143 days.
Daniel, do you want to quickly answer? I can give you Nettie's question because this was the same question I had was, if you want to just go back a slide.
Okay.
Yeah. So does the 82% repeat testing include folks who got the 3 month routine follow-up testing or any test thereafter?
So that includes any patient who received any testing at the Owen clinic. So in other words, that other 18% of patients, we hypothesize that they might have not been followed up with the Owen clinic anymore or left UCSD and didn't get repeat testing or were lost to follow-up. But yes, that 82% includes any repeat testing for STIs. Yeah.
And then the next question is the 21% for test of cure within the recommended timelines. I thought you wanted to explain. We extended the timeline, right? It's go ahead, Daniel. I
Oh
don't.
yeah, yeah, we extended the timeline from 7 days to 31 days. We gave it a bit more of a leeway. We think that the 7 to 14 days might be too kind of a strict timeline to kind of follow, particularly because there might be more false positives around the 7 day mark as well. And so I think extending it would capture the data a bit better.
And there's so many, there are other questions. Maybe, you know what, we'll keep going. So Robert asked the denominators. So test of cure ordered and not completed implies that all 427 participants had a test of cure ordered. Um, that Go ahead, Daniel. I think that's not exactly what it means then.
It means they had a repeat test, I guess, right? That's the top one, but not necessarily a test of cure. Test of cure would be like, I'm bringing you back in 2 weeks for the.
427 is anyone who had a positive gonorrhea or fungal gonorrhea.
Right.
That was what so then the
Let's,
numerator is test
let's
cure ordered and completed.
the numerator.
Like
Okay, so then
93,
of all the people,
all the people,
okay,
93 had a test of cure ordered and completed.
okay. So
Okay.
and then what? Let's see, my thing's in the way. But then 93 plus whatever the next line is. So that's
About 100 people had it from what
at
we
a test of
know,
cure, right? So
a
most of
test
them
of cure
then
ordered.
did it. Okay.
So we this
If you
there's a
use the
lot of
denominator of 427, that means like very few people had the test of cure, very few people completed the test of cure.
that's what that 21% rate means.
Right. But how
Mhm.
many of the people like that had a test of cure, 93? So 93 of 99 had a test of cure ordered and completed. That's pretty good.
Yes, sure, but 300 and
Had no
over
test ordered, but
350 people didn't.
that's a different thing, right? Yeah.
And that
No,
was
no,
not
we don't.
ordered? Those
Sorry,
those
we think
300
there's something not totally correct with this line, which we would have to spend a lot of time going through. We think there were more test of cures ordered and not completed, which was very hard to find with the data analysis that we did. So that was what Daniel was just saying. We don't think this is completely accurate.
Yeah, the orders expire, don't they? So they disappear from the lab order once they've expired.
Exactly. And Daniel started to do a manual review of it, and it was going to be really, really difficult to do.
Okay.
So if that helps, I think that is the one that feels most inaccurate. And that was the one we were, I think, really interested in to see if they were ordered, but someone didn't do it. And it turned out we really couldn't find much with that in almost 430 cases going through it. Well, okay. I'm going to let Daniel.
Yeah. Hey,
go
Jill.
back. Yeah.
Hey, Jill, it's Marvin. Also, I got a private message, and I think it's already passed, but it's just saying any advice for identifying suspected OP gonorrhea.
We'll save that for the end.
Okay, cool.
Yes. Thank you, Marvin.
Okay. And then so for the 11 patients who had a persistent positive test secure, or about 11.8%, 9 of them were retreated. Only about 3 had negative gonococcal cultures that were sent, which were all negative. And then I looked through to see what happened after they were retreated with a persistent positive test secure, and 4 had another positive again, and this was thought due to reinfection. And then out of the entire 11, 2 were thought to have a false positive PCR from early NAT testing. One of that had a gonococcal culture that was obtained, and a PCR both obtained, and they're both negative, so they did not get retreated. And then one had 2 early testing within like 7 days or so, and so they repeated the PCR, it was negative, and they didn't get retreated. And so essentially there were no negative outcomes, treatment failure, or antimicrobial resistant gonorrhea isolates from the patients who had a persistent positive test cure rate. And again, what we talked about earlier, we tried to see if there is any interesting demographic factors that might play a role, for example, with age, race, ethnicity, HIV serostatus, or gender identity, as it pertains to patients who did not have any test of cure or outside the window as compared to patients who were within the window. And so from looking at this data, what we suspect is that people without HIV, they trended to be more likely to complete a test of cure as compared to those with HIV. And then younger patients tended more likely to complete the test of cure as compared to older patients as well. And again, we don't think that the test of cure ordered and not completed rate at 1.4% is necessarily accurate. Like what Dr. Blumenthal was saying, it was really hard. We've revised the data so many times to try to capture those orders that were either canceled or fell off or expired, but it was really hard because usually we just capture the next test that was ordered. And so we weren't able to capture that. So I don't think this number is particularly accurate. Okay, so briefly kind of sharing our data to other centers. In this paper, they estimate that the test of cure completion rate at the US is between 8.5% to 44.2%. So compared to the Owen Clinic, we're kind of right in the middle. Although they reported that the persistent positive TOC rate is about 3.4% to 4.6%. So ours is significantly higher. This is one center. It's a STD clinic in LA that treats men who have sex with men with a high population of 737. And in there, this population kind of reflects their own clinic as well. And in their data, they report that their test of cure completion rate was about 26.3%, so pretty similar to ours. Their positive test of cure rate was a lot lower at 5.3%. And they also did interesting statistics with multivariable logistic regression models to see if there were any interesting demographic factors or behavioral changes that may explain why patients would complete or not complete a test of cure. And they found that patients who had a first time ever diagnosis of oropharyngeal gonorrhea, they were more likely to return for test of cure. And patients who had no symptoms at all were less likely to return for test of cure. Or excuse me, patients who had symptoms were less likely to return for a test of cure once they get treated and they have no longer any symptoms. They don't think they need to be retested. But patients who didn't have any symptoms at all were more likely to return for a test of cure just to confirm that they eradicated the infection. And then this is in one other center. This was a center in North Carolina. And their population demographics included men who had sex with men, men who had sex with women, and women who had sex with men. And their TOC completion rate was much higher at 40.6% and a much lower persistent positive TOC rate at 2.4%. And they thought most of this was all false positives. And I wanted to highlight this center because the population demographic is significantly different than the Owen clinics. And so that potentially could explain why their TOC completion rate is higher and their persistent positive rate is lower. And I was told that the first author of this paper, Jeffrey Jenks, was a prior UCSD ID fellow as well. So that was very interesting. And then so in conclusion, test of cure completion rate at the Owen clinic relatively similar to other centers at 21.8%, which is affected by both patient factors and provider factors. The persistent positive test of cure rate at the Owen clinic is much higher than other centers. And this, I think, is related to a higher risk population that we care for, more reinfections, as well as potentially to early repeat PCR testing. However, having said that, looking at the patients who had a persistent positive TOC rate, there were no complications that we noted. There were no positive gonococcal cultures. There was no noted antimicrobial resistance. And so having said that there has been increasing and emerging ceftriaxone-resistant gonococcal infections worldwide, the question is, do we need to increase our TOC completion rate since it's only 21.8% in order to ensure eradication, reduce the complications, reduce transmission, or on the other side of things, do we even need to do a test of cure in the first place since most patients get retested anyways? And again, about 82% of patients had some sort of repeat testing done after they were treated, and the mean time that they came back was about 67 days. So that's all I have. Dr. Blumenthal, did you have anything else you wanted to add or talk?
No, I figured this would, I mean, there are more questions, and I think what we were really hoping to do, right, was open this up to talk about other practices. We know we have Dr. Tillman on the line, and sort of wanted to hear what the county was doing at this point. So let me go back to the question, because I know, Daniel, you know about this, but was all of this in-clinic testing or were patients given swabs to collect at home?
Actually, that I'm not sure.
Okay, I can take it. I mean, we don't have the data on which was which, but there was a time that we were trying to do that. And I can speak to what my practice was, and other people were doing this. Someone who tested positive for oropharyngeal gonorrhea, we had and I had shared it, I don't know how many people did. We had a dot phrase that we'd put in there, my chart message, that said, you've tested positive, and the practice is that you would repeat this when you come in for your treatment. We will give you a swab that you can take home with you and return in 14 days. Some people, and it became very manually intensive. Some people were given envelopes to try to return it. It became really difficult and very hard to keep up with. So, Winston, I'd say that we tried, but most of it was, I think a few people did self-collect and then would return it. And then a very small minority were self-collect and put it in the mail to UCSD, which I think mostly Christian Turner, who I think is on, helped us try to create, but it really was a difficult thing to do.
Yeah, and I think I had remembered that hearing that people were being given pharyngeal swabs to collect at home, and so that's why I asked the question. And based on experience with our home testing programs, like 40% return rates at the most. I imagine that's challenging to get those back.
I think the problem is we really didn't have someone sort of dedicated to do it. And you see, we have a fairly high burden, although this is obviously over a long period of time. It was sort of hard to operationalize in a lot of ways. And then, and I'll get to Robert in a second, making sure I may just answer Dave's question really quickly. Anecdotally, and others can talk about their anecdotal experiences. I would order them for them to be done 14 days later. They would often get done this same day of treatment. And I was like, well, that didn't go well. And patients were not returning them. And I'd have patients when I'd ask them, oh, you know, we gave you that bag the last time. How did that go? They're like, oh, I lost it, you know, and it seemed very hard to keep up with. Robert, I'm getting to you in a second. Dave, the persistent positive rate among those with 3 tests of cure was 11%. What's the second test positive rate among 350 with any repeat testing done? Can you go back to that slide, Daniel? I think maybe I'm not sure what he's talking about, and maybe you. Nope.
Sorry.
Sorry, Dave. What from that slide, right?
Dr. Blumenthal, I always confuse you on these things. So you gave us the persistent positive test of cure rate of 11.8%, but what was the positive rate in the repeat test done among the people who technically didn't have a test of cure because they didn't meet the window? You know what I'm
You're
saying?
talking about people, any test later.
Well, no, so the people tested positive, right? So they ended up in your sample.
Uh-huh.
And then and 350 of them eventually got another test.
Right.
And what was the positive rate in that group? Which,
Daniel, I don't,
so if you're
all
suggesting
of
that
these,
11
all of
point,
those people had a negative test at some point, I guess is the way to say it, at some point. And Daniel, maybe I think that 11, Daniel, I don't know if you can answer that. The 350 people who had the repeat positive testing, that's any. He's asking how many of those were positive.
We didn't look into that specifically, but that's a good question to look into to see if they had any complications or issues with persistent positive test results as well, despite not getting the test of cure within that time window.
right? So presumably it's an open question whether or not it's a persistent positive or if it's a reinfection or something like that. But, you know,
I think most people end up thinking it's a reinfection.
right.
That's ultimately what happens. But yeah, it's a good question for us to try to look at that.
It could also be very much lower than the 11.8%, which suggests that maybe the people who are symptomatic or, I don't know, perceive that they have a higher risk or something are more likely to do the test of cure than the ones who didn't. So anyway, I was just curious.
Robert, go ahead. Sorry.
Thank you. Again, great job. I think we can all learn a lot from your presentation. Maybe a flow diagram once you get to the manuscript. There's so many different denominators and things, and it's challenging data to pour through. I get it. Like with all the different considerations. So could you go back to the conclusion side? Because I just wanted to raise, I think your fourth point there, this is why we're doing the test of cure emerging resistance that you showed us. And ensuring eradication. It's interesting though, we didn't really see that, right? And in the 11, individuals who had persistence, they didn't have resistance. And so I think you asked the question earlier, like, is this something we need to do? Theoretically, it could get worse. That's a question for you and a question for Dr. Tillman, I think, because I think, Winston, you mentioned that this might be going away in future guidelines. And, if that's the case, what do you think? What are our next steps in addressing this? I tend to think it's less important myself, but
yeah, I don't know.
From the master. Go ahead. Winston.
Oh, well, I don't know about that, but thank you, Dr. Blumenthal. Yeah, so I mean, I'm not sure if there are plans to scrap this recommendation. I know CDC is sort of working on new STI treatment guidelines. I'm not sure what's going to happen with this recommendation. I think the idea is that if someone did have a ceftriaxone resistant strain of Neisseria gonorrhea, that you wouldn't want to wait until the 3-month follow-up to find out that they have persistent infection, in terms of the potential for ongoing transmission. I think, we at the county, we do our test of cures at 14 days. I think if you do tests of cure any earlier than that, especially at 7 days, which is in the range that's recommended by CDC, you're going to get a lot of false positives due to non-viable organisms. There's a nice study from Matt Golden's group at University of Washington that kind of evaluated the time to clearance of an RNA-based nucleic acid amplification test. They basically had people obtain samples daily for 21 days from people, and pretty impressed that they could accomplish that. And they found that the median time to clearance was 3 days, but it took for more than 95% of participants to clear, it took 12 days. And the range was 1 to 17 days. So I think at 14 days, you're less likely to have these positive gnats from dead bugs, essentially. And I'll drop that reference in the chat if anyone wants to take a look at it.
It's just, I'm sorry. I was
Oh,
just going to say, it's just interesting that we explain away all the positives. It's either reinfection or a false positive, or a dead organism, or partner treatment, etc.
Well, when you get the culture and it's negative.
Right.
I mean, I have to say, and I'm not going to say, I'm definitely one of the reasons we have low test of cure rates. I've stopped doing it. I found it to be I was ordering them and no one was doing them. I was ordering it, and then I'd get in these cycles where someone would test positive. I probably have a couple of these cases where we went on for a while and ultimately we got the culture and it was negative, and it created a lot of anxiety for patients, and I think a lot of burden on the clinic to make sure we kept going with it, and it just didn't seem necessary. So Daniel and I, as we talked about this, I kept saying, do we really need it? Do we really need it? I think the title of this talk was, does a second look matter? Question mark. Because my opinion is that if we are doing as Nettie said, a repeat test in 3 months. I hear what you're saying, Dr. Chilman. If you had a resistant case, you wouldn't want to wait that long, but we're going to find it. Somehow, Daniel presented this data a few weeks ago, and our repeat testing was at 95%. And then when we reran it, this is the problem with data that isn't totally cleaned. I believe it now that it's 82%, and that's how many people leave, and we have a population that doesn't stay, and things like that happen. I felt much better at 95% saying, well, if everyone's getting retested at some point, it's great. 82% feels a little bit scary or a little bit more worrisome of, okay, hopefully you're going out into the world and, engaging somewhere else after this happens. But I think my argument would be we're repeat testing, hopefully, if we can, in about 3 months. So does this, and I'm going to respond to Adam's comment, I would never do a test of cure now at 7 days, ever. If someone returned it at 7 days, I would say that was silly. So at least I hope, Winston, if they revise them, they make the window make a little bit more sense, where we know we're not picking up, dead bacteria. So maybe it is 14 to 21 or 14 to 28 days. But I think, sorry, I can stop talking. Let me see. I really just got off on a high horse there. Up on my head.
And I mean, and does everyone who received first-line therapy really need a test of cure? Before it was just people who received any alternative therapy for pharyngeal gonorrhea, and then of course CDC also says there is no alternative treatment for pharyngeal gonorrhea. So yeah, and maybe widening that window or maybe limiting the pool that have tests of cure, I think could make some sense. So I guess we'll see what happens there.
Right. And then there was that question that was a little bit off topic, but I think important, how any recommendations for identifying oropharyngeal gonorrhea. I don't know if Winston, you want to quickly do that in our last,
Sure.
I'm trying to get to the question, sorry.
Yeah. Good question. So, I mean, really, NAT, pharyngeal NAT or nucleic acid amplification testing is how you identify oropharyngeal gonorrhea. There are a lot of data, particularly for MSM, that show that if you sort of limit screening to either people who are symptomatic or limit screening to the urogenital site, you're going to miss the majority of pharyngeal and rectal infections. And we have some local data as well to support that, although we don't get negative results reported to us. So if people didn't have a positive urogenital test, it was either because it wasn't done or it was negative. But since most people, I think, get urine-based testing or swab, testing at the urogenital site, since that's a lot easier than extragenital testing. We also see that most pharyngeal infections in particular, but also rectal infections are not associated with a concurrent positive urogenital test, if that made sense. So you really have to screen, at all possible sites of infection, including the oropharynx, to diagnose pharyngeal gonorrhea.
I just
it's often isolated.
Sorry, I think Edie's question's a great one, because I think it's a wide ranging question. How is this affected by the ongoing use of doxy-pep? Because I think the answer for, we don't think it's affecting the rates, but maybe some patients aren't returning as much because they think they're protected. Maybe we think as providers, well, you're using doxy-pep, so maybe we don't need to do it. So it may affect both provider and patient behavior because they think there's additional protection. But I think all the data that Daniel has presented is, doxycycline isn't the tool that we need for gonorrhea, and probably even worse for oropharyngeal infections.
So,
your thoughts. Yeah, go ahead, Edie.
Actually, what I mean is if we're treating them and then they're going back to using their doxy-pep, but they didn't get treated, they still have those rare people who still have an infection at a week or two or after their 7 days and are using doxy-pep again and not coming in. Is that going to ultimately affect our resistance as far as?
I mean, we know we have tetracycline resistance, right? That's not how we treat.
Right. No.
That's not how we treat gonorrhea. So are you worried about other bacteria that could be impacted? Because that doesn't affect gonorrhea itself, right? They still need to get triaxone.
Right. But I mean, so they got their ceftriaxone, they went out, they had sex with other people because, they didn't wait the whole 7 days, first of all. And then they sometimes take their doxy-pep afterwards. Is that going to, population-wise, make any other effect?
I think it would just increase tetracycline resistance. And this isn't the focus of this talk, but I think we will come back to, we're doing another project looking at doxy-pep rates within Owen. And I think maybe the county has some of that data. We should probably try to talk about it together at some point. Winston and I started those conversations. But there was a great paper out of the same group, Matt Golden, that did show increasing resistance into bacterial strains, that could become of consequence unrelated to STIs. So I think these are all important things to talk about, but obviously not necessarily about this. But thank you for bringing that up. And sorry it's a little bit late, everybody. Okay. Thanks, everyone. Sorry it's a little bit late. Thank you so much for joining us. Dr. Ho, fabulous. We'll all look forward to the paper at some point.
Thank you.
And good luck to you next year. Bye, everyone. We'll see you next week.